Good evening, everyone. I'm Tony Segreto, and once again, honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you. Tonight, we're going to focus on a critically important topic. We're talking about women's cancers and the newest innovations in treatment and early detection. The numbers bear out here on why this health concern is so vitally important. Breast cancer, for example, affects a staggering 1 in 8 women and is the second leading cause of cancer death for women worldwide. Gynecologic cancers impact 47 out of every 10,000 women nationwide. Our team at Sylvester is renowned for their breakthroughs in treating women's cancers, including targeted genetic testing and therapies. Tonight, we're going to examine some of those innovations in treatment and discuss the best methods of early detection. We're also going to look at what Sylvester is doing to address the greater burden of cancer among women from underserved communities. This is going to be a really, really meaningful evening, ladies and gentlemen, because we put together an incredible panel. I like to say this is, again, one of those Mount Rushmores of panels because we have extraordinary men and women who are so passionate about what they do. And they are led by Dr. Stephen D. Nimer, director of Sylvester's Comprehensive Cancer Center. He's also the Oscar de la Renta Endowed Chair in Cancer Research and professor of biochemistry, molecular biology, and medicine. He's going to be joined by Dr. Matthew P. Schlumbrecht, who, among his many titles, is the co-medical director of the Sylvester Survivorship Program and co-director of Cancer Control and Prevention. He's also the interim chief of the Division of Gynecologic Oncology. Joining us also tonight is Dr. Francis Valdez Albini, an assistant professor of clinical medicine, and Dr. Neha Goyal, an assistant professor in surgical oncology, and Dr. Jose Net, the Director of Breast Imaging Services at Sylvester and Associate Professor of Clinical Radiology at the Miller School. See what I said? It is truly a world-class group of experts. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Nimer has delivered his opening remarks, all the panelists will answer the questions that you've been submitting over the past few days. But you're also going to have the opportunity to submit your questions during this program live. For those of you who have been with us before, you know the drill. For those of you new, at the bottom of your screen, you're going to see a Q&A feature. That's where you're going to send us your question. A reminder, every question submitted will be anonymous, and we promise, we've got an action-packed hour here, but we promise we will get to as many of them as we possibly can. But now, it is my distinct honor and pleasure to introduce not only an outstanding doctor, but a dear friend, Dr. Stephen Nimer. And Dr. Nimer, thank you so much for joining us. It's great to see you again.
Good evening, Tony. It's great to see you also. And we're so delighted to gather tonight to talk about women's cancers. I'm very proud to represent Sylvester. We continue to grow. We continue to hire more and more experts in different cancers. And tonight, you're going to see a little bit of our expertise as it pertains to women's cancers. Women can get lung cancer and colon cancer and leukemia and other cancers, and there may be some unique issues that relate to women who develop those cancers. But tonight, and when we refer to women's cancers, primarily we're talking about breast cancer and gynecologic cancers. And so breast cancer, as you mentioned, is a far too common occurring cancer in women. Fortunately, we have ways of screening and early detecting breast cancer. We also understand something about the genetics. And for gynecologic cancers, there are some of these cancers are on the rise, others are not. But as you know, Pap smear is an extremely effective way at detecting the earliest signs of something that may turn into cancer. And so very important that we take advantage of those screening and, as you said, bring things into the underserved minorities in our community. And for the other cancers, particular things like ovarian cancer, where it's not that easy to detect, we're continuously working on ways of developing blood tests or other types of tests that can diagnose this early. The earlier you detect cancer, almost across the board, the easier it is to develop to have good outcomes. And so tonight, we're going to talk about prevention, genetic risk, early detection. We're also going to talk about new treatments. And I also think you mentioned Dr. Schlumbrecht has got a leadership role in our survivorship program. It's very important to focus on survivorship. Uh, More and more cancer survivors in the United States than ever before. There's nearly 17 million people in this country who are either living with cancer or who have had cancer. And so it's extremely important that everyone go back to live a normal life. And so we have a very strong effort in cancer survivorship. Um, in terms of our clinical trials, as you know, 2019, we became the only NCI designated cancer center in South Florida, one of only two in the state. And there are lots of treatments that are only available at NCI designated cancer centers, and you'll hear about this tonight. So we've got a bunch of real experts in women's cancers. You've introduced them all. Let me just very briefly say Dr. Matt Schlumbrecht is an expert in gynecologic cancers. His work has had already a huge impact on women from Little Haiti and elsewhere, and women in the Caribbean who develop cancers and have certain genetic risk factors. And so he's going to talk a little bit about his work in the context of some of the questions tonight. Dr. Jose Net is an expert in radiology and imaging of the breast with ultrasound and MRI and mammography, and he can talk about some of the latest techniques. Dr. Neha Goel is one of our top breast cancer surgeons, and she also is doing a lot of work in underrepresented minority communities to try to make sure that everyone has access to the most cutting edge prevention, early diagnosis, and treatment approaches. And Dr. Francis Valdez Albini is one of our top medical oncologists whose practice is heavily weighted towards breast cancer and who's involved in giving the latest treatments, hormonal treatments, chemotherapy, and other approaches. So you'll hear from everybody tonight. We look forward to the questions. And of course, we look forward to you moderating, Tony. You always do a great job, and you stimulate us to do our best job. So thank you.
Thank you, Dr. Neimer. As always, I'm honored to be here and to be with this. I mean, literally star-studded. This is quite something. So let's get going. We have a lot to get to tonight. We're going to start. Dr. Valdez, you're kicking it off for us. You're the leadoff hitter. What novel therapies and/or therapeutics are being studied for the treatment of breast cancer?
So thankfully, there are many, many things that are being investigated. I'm going to highlight a few that we're investigating here at Sylvester. One I want to mention is an AKT inhibitor that's being used in combination with Taxol, and comparing this combination to Taxol, which is a standard of care. So the novel approach is looking at this additional mTOR inhibitor to see if it will add to or improve the outcomes for patients that are receiving Taxol as standard of care. So that's for our patients with advanced triple-negative breast cancer. Another study or agent that I'm excited about that we're looking at for advanced hormone receptor positive breast cancer is an oncolytic virus. It's called pelareorep. It's actually already been studied in combination with Taxol for patients with advanced hormone receptor positive breast cancer, but it's in its early stages, and it has shown improved outcomes for our patients with advanced hormone receptor positive disease. But what we're doing here at Sylvester is actually looking at it in combination with another immunotherapy, a checkpoint inhibitor, to see if that triple combination will again improve outcomes for our patients beyond standard of care. And this is for our patients with hormone receptor positive advanced breast cancer. Now, my two particular trials, which are actually for patients with advanced disease in the experimental therapeutics clinic as part of our phase 1 program, are two particular trials or agents that I'm interested in. Is one, MT511, which is a targeted agent for patients with advanced HER2 positive breast cancer. So for patients who have advanced HER2 positive breast cancer or refractory to our standard of care therapies, they can come see us and we can consider this agent, this MT511, which is a novel anti-HER2 antibody bound to a Shiga toxin. And in preclinical studies, it looks like it has the potential to overcome resistance to our current therapies. And we have a second study, very interesting, ATRC-101. It's a novel therapeutic. It's a monoclonal antibody, and it's actually being offered for patients not only with breast cancer, but also ovarian cancer, again, in the advanced stage setting, that are refractory to other treatments. This will offer them a novel approach to the treatment of breast cancer. It is an immunotherapy. It's a monoclonal antibody, and preclinical studies show that it tries to engage the immune system, tries to engage your T cell response and lead to T cell mediated destruction of the cancer cells. So a lot of novel therapeutics for our patients that need alternative options. We also have a lot of agents that are being investigated in the early stage setting, but we may touch upon that later. I did want to highlight these. The latter two are part of our phase 1 program, and the other two studies are also for our patients with advanced disease, but novel therapeutics, again, to improve outcomes beyond what we have available now as standard of care.
Dr. Albini, thank you, and a lot of hope as well. Dr. Nett, welcome. What are the latest technological advances in breast cancer screening, and what about contrast-enhanced mammograms and ultrasound and MRIs?
Excellent question. There's a lot of work in the realm of improving the accuracy of the images that we interpret to better get a handle on what lesions we need to bring back for further evaluation and which ones we can dismiss. So in that realm, there's a lot of focus on higher resolution detectors for mammograms. With regards to artificial intelligence, there's also the ability to look at studies before the radiologist gets to them, and they're able to prioritize which ones need to be evaluated to kind of minimize the amount of time from diagnosis to treatment. And you also touched upon one of the latest developments, which is contrast-enhanced mammography, which performs almost equivalent, if not better, than breast MRI at a much cheaper cost, and also at a much easier experience for the patient. Two of those things we actually just rolled out at Sylvester within the last year. One of those is the high resolution mammograms. We're able to get really beautiful pictures without increasing radiation dose, and they're much, much more accurate in finding tumors much smaller. And when they're around, to tell how much tumor is really there or the extent of disease, which is really important in determining the treatment. All of those images are actually run through a very cutting edge advanced artificial intelligence program, which looks for different signs that have already been signaled to the machine that are abnormal, and it makes sure that the radiologist sees those images, so kind of minimizes distraction. We also are very fortunate to have access to contrast-enhanced mammography, which I really love this tool. It's an almost instant diagnosis when you perform it on the patients. So we're really lucky with both of those items being available system-wide.
Thank you, Dr. Nett. It's really amazing how far we've come in such a short period of time with all of the imaging. Dr. Goyle, welcome. Are there any advancements in surgical techniques to improve cosmetic outcomes after breast cancer surgery?
Thank you, Tony, for this excellent question. So at Sylvester, we actually take great care in providing excellent cosmetic outcomes by carefully planning our breast incisions. So every case that I do, I really think about where the scar is going to be, and to ensure that I can safely, oncologically, appropriately remove the breast cancer by making sure the scar can also be hidden. In addition, we offer local therapies in terms of oncoplastic reconstruction to give the breast its shape back for women to maintain their projection. Furthermore, we're really working to try to improve nipple preservation. And that's a technique where we have to, in cases when we have to remove the entire breast, we have special instruments that allow us to actually save the nipple nowadays. And we're even working on new techniques for nipple sensation preservation. In addition, we use treatments nowadays before surgery, such as chemotherapy, to reduce the size of larger tumors and tumors that might be in the axilla, to try to decrease them, which allow us once again to perform potentially more cosmetically appealing surgeries if appropriate oncologically. In addition, in the case where we have to remove the entire breast, or perform a mastectomy, we have reconstruction options, including implants and even tissue-based reconstruction, which uses muscle and fat from one's abdomen, and actually it's transferred up into the chest to reconstruct the breast that way, giving a more natural outcome. And these are all techniques that are done by very few centers, so we're honored to offer these at Sylvester.
Amazing. Dr. Goyle, thank you. Dr. Schlumbrecht, it's so nice to have you with all your responsibilities. I'm just glad you could fit us in. These questions are for you. What are the latest in screenings and treatments in the early detection of cancers that are traditionally difficult to diagnose, such as ovarian cancer?
Thanks, Tony. It's my pleasure to be here tonight. One of the things with a lot of GYN cancers, apart from cervical cancer, is that there's no screens. So we unfortunately have to wait for women to develop symptoms. And in many cases, especially with ovarian cancer, that happens at late stages or advanced disease. One of the things that has been studied extensively is a blood test called a CA-125. Now, CA-125 has not really shown to be a really good predictor of cancer because it can be elevated in a number of other benign diseases. But there have been studies looking at CA-125 in combination with other lab studies, which have shown a little bit more predictive capability in women who've got an abnormality on the ovary. There have been studies as well looking at pelvic ultrasound in combination with CA-125 to see if we could come up with an algorithm that would be predictive. Now, unfortunately, there was a study that recently was reported out of the United Kingdom that indicated that actually has poor predictive value. So we're looking to get a little bit more scientific. One thing that's very exciting now is using cell-free DNA, which can be detected in the blood as a possible screen. So cancer cells, when they rupture, will release their own DNA or genetic material, which can be detected in a blood test. Now, this kind of technology is undergoing rigorous study right now, so it's not available for general community use. And clearly, we want to make sure it's cost effective and won't expose any women to any undue procedures. But in terms of screening for ovarian cancer, I think that's probably the most exciting thing and may change the face of our field here within the next several decades.
Sounds like it, Doctor. Thank you so much. Dr. Neimer, you sort of touched on this in your opening remarks, but the question goes like this: why is it important to be treated at an NCI designated center like Sylvester?
Thank you, Tony. You know, cancer is a very complicated disease. And as the treatments evolve, generally they involve a multidisciplinary approach. You may need the surgeon, you may need the radiation oncologist and the medical oncologist, and you may need a cardiologist and a pulmonary doctor, et cetera. So the team approach to your care is really what characterizes our cancer center and NCI designated cancer centers. And so, of course, the designation means that according to the National Cancer Institute, we are one of the leading cancer centers in the United States, and that the research being conducted here also bears sort of a seal of approval from the National Cancer Institute. But what happens here, Dr. Goel, for instance, has 5 or 6 other surgical oncology colleagues who all do breast cancer surgeries. And they have a meeting and they talk about every case. And so it's not only that you may see Dr. Goel, but you get to see, in essence, the opinion of 5 other surgeons, all of whom are in a university setting, all of whom are involved in research and education. And the same goes for Dr. Schlumbrecht, and the same goes for Valdez Albini and Dr. Nett. Each one of us does not function independently. And so we attract the best pathologists, the best radiologists, and it all matters. And so every little bit counts. And the other thing I would say is that we try to be on the leading edge. You know, NCI designated cancer centers are doing the latest treatments, the most promising things. And in community hospitals, people tend to do what's been published, which is the past. You know, what has worked in the past. Of course, we do that also, but we're trying to figure out what is the future for these diseases.
It all matters. It all matters. Thank you, Dr. Neimer. Dr. Valdez, this question was just sent in to us. It goes like this: I've heard a lot about CAR T-cell therapy, a type of immunotherapy. It seems very promising. Are we any closer to this being a reality where our own immune system is modified to attack the cancer cells?
So thank you. With respect to CAR T cell therapy, I think even Dr. Neimer may be able to comment better than me. We have not utilized that form of immune therapy for, I don't think solid tumors in general as of yet. If it is, it's investigational, but definitely not for breast cancer. Now, with several of the studies that I alluded to, plus the current studies actually, or agents that are available like immune checkpoint inhibitors, we are trying to expand the use of immune therapies in breast cancer, whether it be through vaccines, the checkpoint inhibitors, the pelareorep oncovirus, trying to change the tumor microenvironment. So yes, there are definitely ways that we're trying to explore, and a lot of our studies are utilizing immune therapies, just not CAR T cell therapy as of yet for solid tumors for breast cancer.
Dr. Neimer, would you like to weigh in on that?
Yeah, I would just simply say I agree with Francis. The CAR T cell approach has worked so far better for the blood cancers, leukemia, lymphoma, myeloma. There are some promising results now in brain tumors, primary brain tumors. And so in breast cancer, most of the approaches have involved other ways of stimulating the immune system to recognize the patient's cancer.
Thank you, Dr. Neimer. Thank you, Dr. Valdez. Dr. Nett, I know this question is probably asked of you a lot. With all the differing recommendations out there regarding when to screen and how often to screen women for breast cancer, how should I decide which recommendations to follow?
Yeah, Tony, you're right. This is a daily dialogue in our clinic. So whenever I engage in this type of dialogue with any patient who asks it, the first thing I state is that my recommendations are based upon what my goal is as a breast imager for my patients, and that is finding breast cancer at its earliest stage, because we all know that that leads to the best outcomes. So when you look at all of the different recommending bodies, the only difference between them is when to start and how frequently to perform the test. And those all really vary based on the different risk and benefit ratios that they apply to their recommendations. And I simplify it for all of my patients and say, if you want to have the best chance of not dying from breast cancer and have the best chance of not needing intense chemotherapy to treat your cancer or need more extensive surgery, then annual mammography beginning at the age of 40 is your best bet.
Thank you, Dr. Nett. Dr. Goyle, are there any novel surgical techniques to reduce the complications of lymphedema after axillary surgery?
Yeah, thanks, Tony, for this question. So this is critical for breast surgeons, and this is something that we're continuously trying to reduce the risk of. Lymphedema, like you mentioned, is basically it's arm swelling after surgery, and we routinely remove the lymph nodes to make sure that disease hasn't traveled to the lymph nodes. So these are procedures called sentinel lymph node biopsy or axillary lymph node dissections, and they lead to a risk of lymphedema or arm swelling in up to 5 to 20% of women. So we're consistently trying to reduce that risk because it can really affect one's quality of life. We've started a specific lymphedema management program here to treat patients with lymphedema through physical therapy, but also using novel surgical techniques such as lymphovascular bypass, where we actually suture the lymphatic vessels and sew them to the veins to allow the drainage of the lymphatic fluid to go back to the heart as it should. We actually even offer this treatment at the time of their original surgery to help reduce the risk of lymphedema. So we're really working hard to try to reduce this complication for women that's not uncommon.
Thank you, Dr. Goyle. Dr. Schlemblick, does Sylvester have any clinical trials for gynecological cancer patients that were developed at Sylvester?
I think so. Yeah, we absolutely do. And much like what Dr. Valdez was discussing earlier, we have a real interest in immunotherapy. So we've got 2 studies which were developed by my colleague, Dr. Marilyn Wong, which utilize immunotherapies, which essentially rev up the immune system and allow it to act better on the cancer. One is used in neoadjuvant chemotherapy for women with ovarian cancer. We know that chemotherapy causes a lot of inflammation within the tumor. So the addition of an immunotherapy to standard chemotherapy has been shown in our preliminary results to actually augment response. So that's actually really exciting. The second study that we've got developed here at Sylvester includes immunotherapy in patients who've got metastatic or recurrent cervical cancer. Cervical cancer, in the majority of cases, is caused by the human papillomavirus, which is an infection that many people acquire at some point during their lives. And so the rationale for using immunotherapy is that because this is a cancer which was caused by a viral infection, that there are already some immune cells present within the tumor, and that's been shown previously. In our preliminary results for that study as well, we've shown amazing responses by including immunotherapy with standard chemotherapy. So we're excited to get these trials to closure and be able to publish results and share them with everybody.
Doctor, thank you so much. Dr. Neimer, excuse me, can you explain why the survivorship programs like Sylvester's are so critically important? You touched again on this in your opening remarks, but if you could go a little bit deeper in that for us, please.
Sure. Part of our goal is always to get more effective therapies that have fewer side effects. And by saying that, we admit that some of our treatments have side effects that need to be managed. And so we've built programs to support, in this case, we're talking about women tonight, women who are have had surgical procedures, who've received chemotherapy or radiation. And there's a long list of things that women need to go on and live a normal life. Dr. Kristen Rojas is one of our new recruits, and she is an expert in sexual health after surgery. And we have programs for weight reduction. You know, some of these cancers, breast, ovarian, and recurrence of cancer goes up when women become obese or are obese or overweight. And so some of the medications that we use to treat cancer can themselves cause people to gain weight. And so it's a very important component. Exercise, mental health, and weight reduction strategies. And so we work together in a very culturally sensitive way with women from different backgrounds to find the best approach so that women can live the longest and have the fullest life. There's things like brain fog from chemotherapy. And so we have research going on. How can we prevent these things? And how can we, deal with all of the complications of cancer and its treatment?
Thank you, Dr. Neimer. Dr. Valdez, what type of clinical trials is Sylvester involved in that women with metastatic breast cancer can benefit from?
I think I alluded to a few of them, so I'll just again highlight some of the ones that I'm most excited about. Again, for the hormone receptor positive advanced breast cancer patient that may have failed frontline hormonal therapy, we have this very interesting trial looking at Taxol, which is a standard of care therapy, but comparing that to the addition of this oncolytic virus, stimulates the immune system, adding in a checkpoint inhibitor to further stimulate one's own immune system to help the chemotherapy attack the cancer cell. So that's a very exciting trial. It's the BRACELET study. We have two frontline trials for advanced triple negative breast cancer. One I mentioned, it's the Taxol versus Taxol plus an AKT inhibitor, plus another one that is more based on immune therapy, adding that to standard of care chemotherapy for advanced triple negative breast cancer. This is a good study because I think, we know that checkpoint inhibitors have been approved for a certain subset of patients with advanced triple negative breast cancer, but I don't think there's a limitation there. So this study assumes that most patients could benefit from immunotherapy that have advanced triple negative breast cancer, and it's giving all patients frontline chemotherapy with a checkpoint inhibitor, followed by maintenance non-chemotherapeutic regimen of PARP inhibitor with the immunotherapy. And this is Key-Link. This is the Key-Link study. We have the two phase 1 studies, again, looking at MT511, the Shiga toxin new approach combined to an anti-HER2 antibody for our HER2 positive patients with advanced disease, as well as the monoclonal antibody ATRC-101. We have a frontline trial for HER2 positive breast cancer, looking at standard of care versus standard of care, plus an alternative checkpoint inhibitor, again, for HER2 positive disease, trying to see if harnessing in or engaging the immune system will improve outcomes beyond what we already have, which is we have good standard of care, but the goal of these studies is to improve upon standard of care for our patients with advanced disease and to improve outcomes. So lots of options for all the different subtypes of advanced breast cancer.
A lot of options indeed. Dr. Valdez, thank you. Dr. Neff, this was just sent in. How far apart should CTs and PET scans be done for advanced breast cancer?
You know, the protocols vary with different types of breast cancer, and subtypes really depend on what kind of systemic imaging we would perform. I think Frances might even be able to, Dr. Valdez might be able to comment further on what her protocols are for her patients, but I think it's very patient specific. And it depends again what their disease burden is to begin with. But most protocols don't recommend more frequent imaging than 2 times a year. We're talking about systemic follow-up for metastatic disease or surveillance. I don't know if Frances has any more comments on that note.
Yeah.
What she does.
I mean, the only thing I'll comment on for patients that are on trial, still, you know, patients often ask for a PET CT scan, but historically and traditionally, we actually, for our patients on trial, when we're monitoring their disease, and on trial, we tend to actually probably monitor a little more closely every 8 to 9 weeks or so. And that most studies utilize CAT scans. It's based on tumor size measurements, but a PET scan can be used as an alternative. It gives different information if we're trying to look at the tumor viability. If we're convinced that perhaps a tumor, even though it hasn't shrunk significantly, we want to see the activity within the tumor cells, the PET might add that information, but it is actually very patient specific. I think we still, for our solid tumor patients, tend to utilize frequently the CAT scan, not always utilize the PET scan. Again, for our study patients, it's mostly CAT scans, and occasionally we might add in the PET scan as well for the off-study patients that we're trying to assess tumor viability and try to assess a tumor beyond size, beyond measurements.
And Dr. Valdez, thank you. Dr. Nett, thank you. And Dr. Goyle, this was just sent in as well. Regarding hormone positive BC that may or may not be advanced, since estrogen is stored in fat cells, and since the aromatase inhibitors, also known as ALS, keep weight on or encourage weight gain, one, how do those of us on the ALS who are overweight win at this? Number two, how do we lose weight? And number three, does staying overweight counteract the effect of the ALS for those with low recurrence rates? It's a lot in there, but I know that this was submitted with a lot of thought behind it as well.
Great, thank you, Tony. I will absolutely answer some of these, and I'll defer some to Dr. Valdez as well. But briefly, so in terms of how AIs actually, it's a very good point. How AIs can actually lead to weight gain, but then how do you reduce that weight gain? So as Dr. Nimer mentioned, we have many programs here that really help patients either through dietary programs that we have through support, nutritional programs, and also weight loss programs that really work with patients to try to develop a specific program that works for them. In addition, a lot of our patients have side effects from anti-estrogen therapies, such as aromatase inhibitors and tamoxifen. And we've started a program, specifically Dr. Rojas has started this program called MUSIC, and it stands for Menopause, Urogenital, Sexual Health, and Intimacy Center. And it basically focuses on patients and their individual symptoms from anti-estrogen therapies, such as weight gain, or such as early menopause due to cancer treatments, and hot flashes and vaginal dryness. And this program really utilizes a wider range of treatments from physical therapy to estrogen replacement therapies, specifically vaginal, to really try to reduce the symptoms of systemic anti-estrogen therapies, such as AIs that were mentioned. And so once again, this is one area where we're really trying to work with our patients to improve their quality of life. And then I'll let Dr. Valdez answer the third part, which is specifically looking at how does staying overweight counteract the effect of AIs and how that relates to potential lower recurrence rates.
I mean, this is an ongoing issue and struggle, I think, for our patients, right? We're giving them treatment. A lot of the premenopausal patients, we're inducing menopause. For the postmenopausal patients, we're exaggerating menopause. I mean, we're not helping all of you in terms of the effort to maintain ideal body mass index. But still, the benefit of these anti-estrogens outweighs these side effects. And has been alluded to, we try to encourage patients to seek recommendations from our nutritionist. We now have an exercise physiologist to try to get patients on an exercise program to balance their, the intake versus the usage of their calories. And really promote, we know there are studies demonstrating that 3 to 6 hours a week of exercise, of regular exercise, can improve outcomes with respect to decreasing risk of recurrence of breast cancer, and really having sort of an ongoing effort in terms of, good dietary habits and increasing exercise so we can maintain these anti-estrogens, which are absolutely necessary and maximize, improve outcomes. But it's not easy. Yeah.
Dr. Valdez, thank you. Dr. Goyle, thank you. Dr. Schumblick, we just had this sent in, and the question actually was, will anyone be talking about a rare type of cancer? So the question is vulva cancer. Can you tell us a little bit about that and where we stand at Sylvester with that?
Sure. So vulvar cancer is incredibly rare. In the United States, there are only about 2,200 cases a year. Vulvar cancer, much like cervical cancer, in the majority of cases is caused by exposure to the human papillomavirus and has a very long kind of indolent pre-malignant phase before it turns into malignancy. Now, one of the challenges with vulvar cancer is that because there are so few patients who get it, and particularly patients who have recurrent or advanced disease, that it is an incredibly difficult disease to study. So the majority of data that we extrapolate from with regards to treatment comes from cervical cancer data. Now, there was a report, again, looking at immune checkpoint and immunotherapy combination that was released last year that did seem to have some promise in patients with vulvar cancer. So in terms of novel treatments, we are starting to use increasing levels of immune checkpoint and immune therapy for our patients with vulvar cancer, recognizing that chemotherapy and radiation in and of itself may not be sufficient. But the individual asked the question, asked a great one, because unfortunately, that's one of those diseases where we just haven't made quite as much progress.
Doctor, we're going to keep you here because this was literally just sent to me. What is the latest and what kind of treatments for uterine cancer do we have?
So the treatment algorithm for uterine cancer has evolved significantly over the last 40 years. And one thing that's really important to appreciate is that there are multiple types of uterine cancers. There are those that are responsive to hormones, and then there are those that are not. More recently, there was a study that came out that compared our standard of care, carboplatin and Taxol, to what had previously been a very toxic standard of care, really kind of establishing Taxol carbo as what works the best, regardless of the histology. Once you start looking at specific subtypes, we really get quite nuanced. So one thing that we do for all of our rare tumors, and especially the endometrial cancers that recur, is send them for what's called next generation sequencing. So that's looking for gene mutations within the tumor. That really allows us to identify a couple of things. One is this a tumor that's going to respond to immunotherapies? And if it's not, is it a tumor that would respond potentially to another novel targeted therapeutic? So one of the fascinating things about endometrial cancer, when I reflect on my practice and our practice here at Sylvester, is that I would say the majority of us do not primarily utilize chemotherapy in the treatment for those diseases. And so it's really important to understand where the weaknesses are in the cancer's genetics and exploit them as much as possible.
Thank you, Doctor. Dr. Nett, here's another one that was just sent in to us. What are the indications for contrast-enhanced mammographies?
This is a really great question. You know what? Any patient that wants one at our institution can get one. I think that's an important piece of the puzzle. And in most high quality centers, that is the protocol, but the accepted indications would be those women who are not quite high risk, meaning their lifetime risk based on different factors is less than 20%. Average risk, to put it in perspective, is between around 10 to 12%. So those women that fall in between that, and that could be due to having dense breasts, having prior breast procedures that yielded high-risk lesions, family histories, for example. Those patients would be an excellent population to utilize this for annual mammography because the contrast mammogram does replace that annual mammogram. Additionally, women who are elevated risk, like a greater than 20% risk or new diagnosis of breast cancer, but can't get into the MRI. And the reasons for that would be a contrast allergy that's too severe to pre-medicate for. They might have a cardiac defibrillator or something that's not compatible with our MRIs, or have severe claustrophobia because the exam is definitely a different exam considering it's just a conventional mammogram with contrast on board. Those would be the main indications. We also like to use it when the imaging is just so complex, and this happens every day in clinic. We have 10 to 12 lesions, and you will have some patients that will say, I want all of them biopsy, and it's just not an acceptable or appropriate thing to do for our patients. It's just too much to put our patients through. So we help, it's called problem solving. You'll put them into the contrast mammogram, and you'll be able to see what actually is enhancing and highlights it for further workup and interrogation.
Thank you, Dr. Nett. Dr. Neimer, what is Sylvester doing to break down barriers and increase enrollment into clinical trials? We know how important clinical trials, because we're talking about all these latest therapies and innovations that we're doing now.
Thank you, Tony. And I think tonight is actually going to help us in our pursuit. So one of the key factors is education. So if you don't know what's available, it's hard to understand whether you're eligible or not. And even for your physician may not be aware of everything. So we spend a lot of time with outreach to patients, outreach to other physicians in the community, so they understand what are the clinical trials that are ongoing and who would be eligible. I would tell you, people can also take things into their own hands. There's a website, clinicaltrials.gov, and every clinical trial that's open is on that website. And so we frequently get calls about, are you opening up this trial? Or I heard that this trial is only in California, and where can I get this trial? And so we're very, we have a lot of trials open, and we also can help people get onto the right trial if for some reason we didn't. The other aspect is for people who have difficulty accessing traditional medicine. So we have, for instance, these game changer vehicles. You may have seen them in the community. We have one in Monroe County, one in Miami-Dade. We'll soon have one in Broward. And these game changer vehicles go out, and for people who may have never even seen a doctor in the past, go out and offer education and research. And so, as you heard, we're doing research on early detection and screening. And so we really want everyone in this community to be able to participate in our research activities because we believe they save lives.
What a great, great resource. Dr. Neimer, thank you. Dr. Valdez, this was just sent in, so I'm reading it cold to you. What second-line endocrine therapies are used for ER plus HER2 MBC with liver mets, the patients who are not candidates for surgery?
Repeat the question. What second-line endocrine therapies are available for patients with advanced hormone receptor positive breast cancer?
This is ER plus HER2 MBC with liver.
Okay, so I think that's, again, hormone receptor or ER positive, HER2 negative. So second-line endocrine therapies, we do have a trial, the PACE trial, I haven't mentioned this one before, which is looking at standard of care Faslodex versus that in combination with our frontline CDK4/6 inhibitor versus that combination along with an immunotherapy checkpoint inhibitor. So that might be an option for the patient. In addition, we would do next generation sequencing or test the patient's tumor for additional mutations, because if they harbor a PIK3CA mutation, we could offer alpelisib along with fulvestrant. That would be a standard of care off-trial option. We also have the option of everolimus or Afinitor along with exemestane. So there's actually second and third line options on or off trial. I hope that answered the question. If not, please resend.
We'll have them redo it again. But Dr. Mutz, I think we did. Thank you so much. Dr. Goyle, was another one just sent in. Are there any treatments to help manage the side effects, PF anti-estrogen therapy, which is often recommended for 5 to 10 years as the breast cancer treatment plan?
Sorry, can you repeat that, Tony?
Sure. It goes like this. Are there any treatments to help manage the side effects, PF, of anti-estrogen therapy, which is often recommended for 5 to 10 years as the breast cancer treatment plan?
So as mentioned, we have the music program here, which really focuses on managing side effects of anti-estrogen therapy. And specifically, it works to target women who might have symptoms of early menopause, might have vaginal dryness, might have pain when having sexual intercourse. Or it uses a lot of treatments such as vaginal testosterone. There's a study called the Tesla study that's starting, and also uses vaginal estrogen. So it's really trying to decrease the systemic effect of anti-estrogens and really try to target specific areas where women can benefit in terms of quality of life issues from anti-estrogen therapy.
Thank you, Doctor. Dr. Schrumbleck, is there anything about South Florida that makes it unique for gynecological cancer research?
Absolutely, and I think everybody here on this call would agree that the population in South Florida is unlike any other population anywhere. We have such significant diversity by race, ethnicity. We've got immigrants, we've got different religious groups, we've got folks from Europe, from South America, from Central America, from Africa. And so what's really fascinating is that we really see everybody kind of come together. And that allows us to lead the charge in terms of understanding how disease etiology and pathogenesis, how responses to treatment, and how survivorship may differ amongst all of those groups or between those groups. Some of our own research within the Division of GYN Oncology has really demonstrated that for certain genetic syndromes that predispose to ovarian cancer, and for specific types of endometrial cancer, that we can see very specific differences by a lot of our groups in South Florida. And what that does is position us to lead in terms of acquisition of grant funding and to develop some really interesting novel approaches to screening, to treatment, to survivorship that allow us to really kind of change the face of oncology for our patients.
Sure. Dr. Nett, are there new early diagnosis methods for women who have had breast cancer?
So, to follow the line of contrast enhanced mammography and MRI and ultrasound, those tools, those are considered adjuncts to your annual mammogram. And women with a personal history of breast cancer definitely have more access to those more advanced imaging studies. And so those would include annual, in addition to your annual mammogram and MRI, if you meet the criteria. And those studies in those patients who have undergone annual combined MRI and mammographic surveillance have been not only found to have tumors smaller, but also have a survival benefit when found. And the same holds true for contrast enhanced mammography. We don't have enough data for survival benefits, but we certainly are seeing that those women who undergo those more advanced imaging modalities are finding more cancer, and they're finding it earlier.
Thank you, Dr. Nett. Dr. Neimer, we have a number of nonprofit organizations in South Florida. What can breast cancer nonprofit organizations do to help the fight against breast cancer?
Thank you, Tony. Yeah, the Breast Cancer Research Foundation, BCRF, Cancer Link, WCA, the Women's Cancer Association, and others are all, one, getting the message out about the importance of screening for these cancers, the importance of understanding your risk, whether it be a genetic risk or lifestyle risk for developing these cancers, and also making sure people understand all of the educational and other resources that are available. Some of these organizations fund research, and so we're very grateful for all these nonprofits that have worked with us to help us raise money to have meaningful and impactful research that saves people's lives. So some of these are national organizations, and we're thrilled to participate. We have some leadership positions on these, but education and also patient support is something that these organizations do.
Thank you, Dr. Neimer. Dr. Valdez, for early stage breast cancer, what tools are being used to detect early relapse and offer patients a better chance for improved survival?
And this is a tough question, an area that requires ongoing investigation. So in the past, we've used cancer antigens, which have not equated with improved outcomes. The CA15-3, 2729, some patients may know what I'm referring to, have just not led to, they're not sensitive enough or specific enough and have not translated into improved outcomes, so they've actually fallen out of favor. More recently, I think Dr. Schlumberg alluded to it, we have been looking at circulating tumor cells, CTCs, or circulating tumor cell DNA. More recently, you may have seen in the news Signatera, which is a more patient-specific circulating tumor cell DNA test. And these tests may be able to pick up minimal residual disease or molecular relapse. We actually don't know yet how to use them, at least in breast cancer. We don't know how to utilize it yet in terms of we're trying to figure out how, with a molecular recurrence, if that's going to help if we institute therapy sooner than a clinical relapse. So right now, we actually are not utilizing these tests on a routine basis. We're hoping as clinical trials go on, we may learn how to utilize these best and see if earlier detection of a molecular relapse will improve clinical outcomes. But right now, we're not there yet.
Thank you, Dr. Valdez. Dr. Schumblick, we just had this one sent in as well. It goes like this. Are we seeing a connection or uptick in hormone receptive cancers in women with polycystic ovarian syndrome? Is there a different protocol to follow when treating patients with both hormone receptive cancer and polycystic ovarian syndrome?
So polycystic ovarian syndrome is a known risk factor for certain types of ovarian cancer, and because it has an association with other risk factors for endometrial cancer, including insulin resistance, being overweight and obese, and diabetes, it is associated in that manner. But a diagnosis of polycystic ovarian syndrome, once a patient is diagnosed with a cancer, does not typically have any bearing in terms of how we treat that patient.
Thank you, Doctor. Dr. Nett, how do I determine if my family is at high risk for breast cancer if I have a family history of breast cancer or if I had breast cancer?
A great question, and one that we encounter also very frequently in our clinic. So basically at every encounter, at your annual mammogram or at your annual physical exam with your primary provider, a risk assessment or some gauge of risk should be undertaken. And that can include a simple intake form, which outlines your personal history of either a prior breast biopsy, any of those biopsies yielding either cancer or a high-risk lesion, and that could be atypical ductal hyperplasia, lobular hyperplasia, LCIS, radial scars. There's a whole host of them that can be considered increasing your risk. We take into account the age when you had your period and when you started menopause and any hormone exposure. All of those things, when we add that together, give you a lifetime risk. And at Sylvester, every patient, when they come in to the breast imaging suite, is assessed for that risk. And so when that happens, we take a look and we look for any signs that might suggest a deeper underlying risk, such as a genetic predisposition to breast cancer. And we can offer them in-clinic genetic testing with a simple oral swab. We can also look at patients who really need a full genetic assessment and a genetic counseling appointment where they can really guide the patient into determine if they need more advanced genetic testing or counseling to put them into a more high-risk category for different cancers, not just breast. And I'm excited that we're within months of rolling out and going live with a high-risk clinic at Sylvester, where patients like this who have this very question can be seen and managed if they are deemed, in fact, to be high risk.
Amazing, amazing things. Thank you, Dr. Nett. And Dr. Goyle, this one was just sent in. Can you talk more about research focus on tackling breast cancer disparities in South Florida?
Absolutely, Tony. This is an area that I'm extremely passionate about. And at Sylvester, we take great pride in really trying to tackle breast cancer disparities as well as ovarian and gynecologic disparities. But briefly, I lead a study called the Miami Breast Cancer Disparity Study, which tackles disparities in our catchment area using something called a cell to society approach. And what that really means is we look at one's tumor biology. So trying to see how race, ethnicity, genetic impact the genome, and really also looking at how one's environment, where they live, where they grew up, really impacts tumor biology as well. So this is called the cell component of everything. And then we see how that translates to their outcomes in breast cancer, and how we can use this information to really target treatments and interventions specific to our communities. In addition, part of the study, we actually have an in-depth survey that really evaluates social determinants of health, barriers to care, barriers to treatment, to really come up with targeted interventions to help our patients in our catchment area really attain health equity, which is our goal.
Dr. Goyle, thank you. Panelists, all I can do is this. I don't know where this hour went. I mean, this was absolutely, truly remarkable. That's going to be our last question for tonight. But before we go, we do have some final thoughts from Dr. Neimer. And Dr. Neimer, you have to be so proud to listen to this team that you've assembled, to know that they are here with us right here in South Florida and at the University of Miami.
Thank you very much, Tony, first for moderating the session and handling the questions. And, you know, the questions ranged from some very specific questions about a treatment to more global concerns about how do we manage disparities and within our population. And I'd like to say that the four panelists tonight, these are incredible, talented physicians, knowledgeable, caring, and the other is that we work in teams. And I hope it's a little bit evident tonight. And we have a common approach. So it's not like everyone can do whatever they want with every patient. We talk about things and we have a philosophical approach based on data and based on what will give our patients the best outcomes. And so just a couple quick things. You heard about CAR T cells. They're not used for breast cancer, but we're one of the leaders in Florida in using CAR T cells and in that research. I didn't mention specifically the phase 1 program, but we have the only phase 1 program in South Florida. And so when we get new agents that are particularly promising, this is where they would be delivered in South Florida. And the other is what's called the ETCTN program from the National Cancer Institute. So there are treatments that are only available at NCI designated cancer centers. And so in breast cancer and in GYN cancer, we have therapies that are available. We hear that sometimes doctors give up on patients or they tell patients that they've run out of options. And we want everyone to understand that there's always another approach and that our people here, these physicians and our researchers, are working day and night to find new treatments, new effective treatments. And so tonight, we're very grateful to so many people who put this on and to everyone who's been listening. Please, I know Tony's going to say things like this that we'll try to get answers to your questions, but not just the questions that you're asking now. We're trying to find the answers to our own questions. How are we going to do a better job taking care of our patients? So we're very dedicated to this. And I can't thank you enough, Tony, for all you do to help the university and Sylvester.
It's an honor, Dr. Neimer. I cannot even express truly to words. And for me, that's odd, but what an honor it truly is. And I just want to thank you, Dr. Neimer. And I want to thank all of you for watching tonight. And our panelists, again, a standing ovation for all of you. You were all remarkable. And, you know, once again, I believe tonight it allowed all of us to look not just behind the curtain, but deep into the brilliant minds of our panelists, whose passion and expertise continue to come up with sound, innovative ways to help women, not just here in South Florida, but across the globe. And I think this bears repeating. And Dr. Neimer, to your point, how truly blessed are we all to have these wonderful doctors with us right here at the University of Miami. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. And in a moment, you're also going to see a survey about tonight's town hall on your screen. Please take the minute, actually it's less than a minute, I've taken it, to submit your feedback, because what this does, it helps us understand your interest and to improve our program. We've given a lot of thank yous tonight. A special thank you to all the people that none of you ever see behind the scenes who help put these programs together. We want to wish all of you a wonderful, wonderful summer. We want to wish your family good health. We want you always to remember, it's all about the you. Good night, everyone.